I first began talking to the public about advanced care planning, I showed up ready to help people face the fear of death that often accompanies conversations about serious illness and end of life. But one afternoon, a couple in their 70s interrupted me right when I was in mid-sentence, and they said, "We're not afraid of death. We watched many of our friends and family members die already. Here's what we're afraid of: dying like they did, with their adult children, insisting on treatment that was inconsistent with what they wanted, making them suffer in their last days. We're afraid of our children not honoring what we want." And so I learned that sometimes we need to listen and learn before we know enough to teach. On behalf of the North Carolina Serious Illness Coalition, welcome to our Thursday focus titled Things You Might Discover When You Listen Well: Perspectives on Challenges and Opportunities from the Family Caregiver and the Clinical Team. Good morning, I'm Keith Stirewalt. I'm a physician assistant, a hospital chaplain, and a medical educator serving as the program director for Faith Health Community Medicine at Atrium Health Wake Forest Baptist here in Winston-Salem, North Carolina. I'm honored to facilitate today's gathering and help to introduce our panelists. As I name each of them, I invite them to provide a brief introduction and to share with us the lens of their perspective for today's conversation. And I first introduce Melanie Kelly. Welcome, Melanie.
Thank you, Keith. So my name is Melanie Kelly. I am an RN. I have worked in palliative care most of my career, and I'm currently the director of palliative care here at UNC Health. However, I'm participating today as a panelist through the lens of a caregiver and a family member.
Thank you. Our next panelist is Melisa Norton. Welcome, Melisa.
Thank you. I am a registered nurse. I have 11 years experience in outpatient palliative care and inpatient as a clinical coordinator. I also have years of experience as an inpatient hospice nurse and manager.
Welcome. Next panelist is Dr. Patel.
Hi there, I'm Sachin Patel. I am a pulmonary critical care physician and have been at WakeMed for the past almost 10 years. I also work at UNC Rex now. And prior to WakeMed, I had the opportunity to work in New Zealand with the Maori community and learned a lot about end-of-life community-based decision-making, and it was incredibly informative. So thank you for having me.
Thank you. And our last panelist is Dr. Shana. Dr. Shana, welcome.
Hi, good morning. I'm Shana Thatanantharajah. I am a second-year medical resident here in Greenville, North Carolina. My lens is someone that is speaking from the transition of medical school to being a doctor and talking to patients and the new things that I'm learning and the struggles that I'm having, I guess.
Thank you. So I have some questions for our panelists to begin with. The title of this session talks about the power of listening. Good listening often follows good questions. Can you share with us the questions you found provide the most insight when talking about goals of care?
I think from my experience with inpatient palliative care, when you're dealing with truly acute situations that have come to a head, the first question that we always asked was, what is your understanding of what is happening? And that definitely gives you a baseline and perspective to start from, a place to build from. What is your understanding, and how can we partner with you as you move through this process?
Partnering, I like that. Others?
I think asking the families what their understanding is a great place to start. Where I take care of patients, it's typically in a crisis situation where there's an impending medical intervention that is life prolonging, and we have to, in a very short amount of time, often determine what the family's understanding is, their healthcare literacy level, and what they truly understand about what we're going to be able to do to them. And that is a very difficult place to start a conversation. But for me, I think just really in a short amount of time, trying to understand where are they coming from, what lens, what socioeconomic, cultural, religious lens, spiritual. So if you can kind of at least get that as a baseline, then it sets the foundation for further conversation.
Thank you. Others?
I would just add from the family lens, I think goals of care conversations, if you word it that way, is very confusing to families, or they don't understand exactly what that means, because from their lens, their goal is cure and to be back to where they were. And it's framing it in a way to families on what we can do for you and how can we align treatment goals with your values. So that would be my feedback or my thoughts from the family perspective.
Thank you. Wording seems to be a theme so far. I'm aware that in my brief stint with palliative care that the term aggressive care or stopping aggressive care had a connotation that patient families just didn't understand and didn't care for. I like the term aggressive healing over aggressive cure, by the way. Dr. Shana, anything for you to add?
Yes, I think I agree with everyone else. I think the most important question is what do you know so far? What do you understand about what's going on? I think I have an interest in critical care, actually. I've done a few ICU rotations, and often the goals of care question comes with such critical nature. And I had this bias into it, goals of care, code status and whatnot, whereas it should technically be two different conversations we have. It's just difficult to navigate sometimes.
So I'm hearing again a theme of cultural context, but also sometimes, unfortunately, being involved in the conversation pretty late in the trajectory, which brings me to my next question. Often I like in my observation, these end of life oriented conversations or goals of care conversations to be like two porcupines with their quills out in a small room. Everyone's afraid of hurting the other person and getting hurt in turn. And so are there questions that you feel we hold back from asking? And if so, what are those questions that we are maybe too hesitant to ask?
I think certainly in an acute situation, it's very touchy because people do come into the hospital and they do want to get better, of course. And sometimes that's not a realistic possibility. So ideally, having come from an outpatient background as well, those conversations are started early when you're first diagnosed with something like COPD or kidney failure or another disease. But just asking, have you thought about what you want the end of your life to look like? Because we plan all these things in our lives, the birth of a child, a wedding, all these different things, but the thought of planning for our death is very taboo a lot of times and surrounded with a lot of superstition. If we think about it, if we talk about it, it's going to happen or hasten it. So I think just asking, have you thought about what you want at the end of your life to look like? And how do you feel about death? Exploring that feeling and that and using the word death is important as well, because we make it very warm and fuzzy to make ourselves feel more comfortable, like when you pass on or when you go to heaven or whatever context we put that in. Just using the word and asking the question, have you thought about this? It's hard and it's uncomfortable. And a lot of times we'll get pushback from patients saying, that person came in here and all they wanted to talk about was death, but it does need to be a conversation that's had.
Thank you.
Yeah, I would also say that my father was treated at a very large cancer institution, and having the background that I have, my sister and I asked very direct questions and about how this is going to unfold over the next several months. I knew it would get harder, and they seemed very reluctant to talk about or to go there with anything, even when I and the family were asking what to expect, how can we help plan. And we finally got a DNR order, a portable DNR order, but it still all came to a head in an ED. And that just really surprised me. I think the other thing that I read about and I know, but when I experienced it as a family member, is who's captaining the ship. We had a red onc doc, we had a medical oncologist, we had a surgeon, bless him, but nobody seemed to be leading the care plan, and it was very fragmented. And it seemed because of that, nobody also wanted to own the conversation about what I knew was coming. And my father made it very clear he did not want to die in a hospital. And yet it still took me knowing what I knew to demand palliative care get involved when we hit the ED. So that was eye-opening at a large cancer hospital with a certified palliative care program, that even being very direct, it seemed very difficult for physicians to go there.
First, thank you for sharing that. And it makes me wonder, because I've been in a similar situation, what about our patients who don't have a family member in medicine who can step in and assert for their voice, for the patient's voice? Others? Well, let's talk about the term goals of care came up earlier amongst several of you. What types of goals do we include in this? And what goals do you feel should be included in a goals of care conversation?
I think one of the most kind of unifying places to enter goals of care in what I do is when patients are now on life support and they're not improving, is trying to determine what is quality of life for that patient who is now unable to speak for themselves. Mm. And so to really do that, it takes on an operational level, you have to slow down your day as a physician in the ICU. You have to make a space for it. It should be in a quiet, separate setting. Family shouldn't be looking at a very visually graphic representation of what critical care, what life-prolonging illness is. But they need to just kind of be away from it. So what is quality of life, and just allowing the time for the family to speak and just listening. It's a very difficult thing to do when there are all these other responsibilities that are out there. So I found that to be a place to start.
I think it's important too, when you have the opportunity to speak to the patient, like I said, in an outpatient setting, or even at the beginning of their acute care setting, maybe they're more cognizant at that point. But what are your goals for comfort? What do you want? I mean, do you want to be aware at the end of your life and less medicated? Do you understand what that looks like? Supporting them and educating them about how we try to balance that very finely, but it can be that we have to medicate you to the point where you're not able to be conscious. Is there anything you're looking forward to or wanting to participate in or do before the end of your life? And a lot of people do have those type of goals. I want to see my grandson graduate. Is that realistic? Is that 10 years from now? Is that really going to happen? So, and just understanding, like I said before, what they want the end of their life to look like. Do they want to be at home? Do they want to keep coming back to the hospital? Because we do have patients that do want to keep coming back, and what that would look like as well. So just supporting them and giving them information as far as, are their goals realistic? How can we partner with them and help them reach those goals? And is that satisfactory?
So I'm hearing goals of care extending beyond the medical context, the social and personal context as well. Did I hear that right, Melisa?
Yes.
Dr. Shana, anything that you would like to add? We've got some great comments in the side in the chat. I want to make sure that our speakers get a chance to present.
Yeah, so regarding goals of care, I think for me, I found the most important question is what's most important to the patient? What were their core values? How would they have imagined their end of life? Is family time more important? Most of the time, they don't want to stay in the hospital. And I guess listening and understanding all the inherent values they have helps.
Thank you. And again, I'm toward the end, we were going to get to some of the things in the chat, but one of the things that was mentioned was to ask the patient, how are you doing at the beginning? Because I'm going to use that as a springboard for the next question. And that is about the role of the caregiver in all of this. And the ethics stuff that I've done in the past, there's been a game of capture the flag, so to speak, between family members and different family members and patients. Often, our chaplain residents will hear from a patient, I'm tired and I'm done, but my adult sons don't agree. And so I'm not doing hospice because I'm going to disappoint them. How do you balance the desires and generally out of love, quite often, the desires of the family compared to what the patient wants?
I think when a situation when a patient is unable to advocate or speak because they are so ill, I think it is the duty of the physician, the provider, to advocate for that patient, to the family that may have different ideas about what the patient would want. And this happens quite often. A patient will start to lose capacity. But in the few moments that we have together, you get a sense, you get very clear clues and words that, I don't want this, that I'm ready to transition. And then the family is incredibly distraught and forced to choose from a large menu of technologies, essentially, with promises of this and that and the other. So I think it is important to slow down and be like, what I hear from your mom or dad is that they understand they're dying and they want certain things honored, and also to empathize with that frustrated family member. I understand that this is a horrible situation you're in, and I can see that it's hurting you. These are skills I was never really taught in medicine, and I'm hoping that the new generation is a little bit better with that. But it is a big struggle in what I do to have everyone on board to use the languages of palliative care.
Thank you for that. I will say that it is being taught in some of the medical programs that I know of, but unfortunately the fear of step one, step two overshadows a lot of what you're talking about. That'd be another great hour-long conference just on that, wouldn't it? Anyone else on that?
I think certainly understanding who you may have a healthcare power of attorney who you're going to for decisions, but they really don't have the power in the family. So understanding the dynamics in the family, who the main players are, You may have the healthcare power of attorney, and then you may also have a decision maker that influences the healthcare power of attorney if someone's unable to make decisions for themselves. So definitely gathering that collateral information and respecting those dynamics within the family is incredibly important.
I would echo that as a family member. It was definitely my mother. My father was articulating what he would and wouldn't want in the context that he knew, but it was definitely my mother. And my dad was willing to go to Seattle for a second opinion if that's what we wanted. And as a daughter, I'm like, yeah, we should do this. He had a very rare cancer, but he did not want to. So families will, for the love of their loved ones, go through treatment or be pushed. And in my case, it was definitely my mom. And even when decisions started to come down, I really had to stay in my daughter lane and not get into my palliative care lane. Because when I looked back, I needed this with my mother's journey.
Mhm. Thank you for that, for sharing that. Let's, we're talking a lot about conversations, which of course is the important part. One of my ex-teaching colleagues is a critical care doctor who said, 90% of my time is actually in communication. So we've had some questions in the chat about how do you do this in the busy day of medicine? Because there are two things that I always notice, and that is there's a shortage of time and a shortage of nurses. And since we don't have a closet filled full of dehydrated nurses to pull out to have new nurses, and I can't stretch Chronos, how do you all make time to have these conversations when there's always the next patient and the next patient and the next crisis? Or how should we?
I think for me, something has to give to stretch that time, and working to increase efficiencies of documentation, I think, is an important thing, but it comes at the sacrifice of the documentation not being this beautiful novel that describes all the little nuances of every molecule that may have changed over the day, which a lot of doctors like to do. Is that going to help the patient? I think it's important to step back when you're trying to practice in a way that honors the specific issue that we're talking about with patients and families. What is my goal and how can I make that time? Well, okay, maybe I have a few candid notes, and they're very short, but I'm going to stretch that time with the family and the patient to really kind of focus on that. I think that is, I think, a practical approach that I have used.
So we deal with, I'm in a tertiary, system here. We are a place where everyone thinks there are miracles that occur here. The only time people tend to die is if we either in medicine do something to them we shouldn't have, or we didn't do something we should. And I think part of this actually goes into healthcare literacy. So I'm sure with the variety of patients that you see and your lenses, there are different, not just healthcare literacy in the terms of understanding terms, but in understanding what medicine can and cannot do. How do you face a family who might think for cultural reasons, maybe good historical reasons, if you were treating me aggressively enough, or you treating my dad aggressively enough, he would get better, and he's not getting better. How do you deal with that very painful part of an interaction?
It is extremely painful, I think, for not just the patient, but also the people caring for the patient. I think a lot of times nurses at the bedside suffer a lot of moral distress from seeing a patient that they aren't able to medicate because of perceptions from the family. I know in my area, it's rural Appalachia, and so there's a big stigma against hospice. It's when you give morphine, you're going to bust their heart. So low health literacy and just a general distrust of authority. I think the biggest part of that is developing rapport and trust. That they trust that what you're saying is real. You have no agenda outside of helping their person, and that you're going to do your best by them. I think that's the biggest part of chipping away at that reserve and that wall. And even in people with very high health literacy, they have a tendency to intellectualize the information and remove themselves emotionally from it. I do. I know I do personally. So allowing them to step out of that intellectual role and really see with their eyes and be in the moment. And I think that part of that's just developing rapport, and it's time, just taking time.
So trust first.
Yes.
Others? So one of the people in the chat mentioned that it was actually the medical people who had more of an issue with, looked like their mother's end of life. And actually, I went through that with my stepmother as well, someone with a most order who was inappropriately sent to the ED twice, only to be sent back. So this is a question that actually goes, I guess, from our medical training all the way into our various practices. How do we do a better job of making people in medicine more comfortable with serious illness and end of life so that we can take better care of our patients? And so I'll step aside and step out of my lane for a second and say, that's one of the things that I do with usually one-on-one is I'll find someone who's been practicing for a while who said, you know, I realize I do have a problem with patients dying. But they won't admit that to their colleagues, no matter what their role is. How do we do a better job of this? Because we need to, and we need that, and that's part of taking care of us too, right?
I think that goes to just more education in both nursing schools and medical schools. When I went through nursing school, I think maybe I got one module, 1 hour on end of life, maybe. But, you know, I don't think, at least historically, that there's been a lot of preparation for end of life or how to care for patients at end of life, or that it happens.
Yeah.
But I experienced some of the same things. I will never, in the ER, this particular hospital we were at had a palliative care unit, and we were waiting for a bed, and I had a nurse describe to me how they stop everything and it's barbaric. I'm like, oh. And I mean, I'm educated, and I was like, I'm all right, I'm not going to go there. So it is true. I think there is just a lot of discomfort out of lack of education. And the other thing, as I worked with nurses, while I deal with a lot of end of life and serious illness in palliative care, a lot of nurses don't every day. They get 1 or 2 DNRs a year, perhaps. And of course, that depends on where they're working. But as I've done education, that in the hospital setting, not all healthcare professionals are seeing it every day.
Others?
I think certainly being able to divorce ourselves from the outcome, not be so invested in having a particular outcome, and understanding that they have an autonomous right to choose whether we think it's right or not, is incredibly important. That death is not a failure. It's not that we failed them. This is a natural part of life. and that we have to accept it as well. Maybe it's a part of us that we can't accept our own death. I don't know, but understanding that it is a natural part of our process as humans.
I'm big into healing when cure is not possible, and I think sometimes death is healing. So, other
One of
thoughts?
the challenges in medicine, in the medical education process, is that culturally, we're in a very different place in the last 60, 70 years than medicine was, before that. I think the advent of all the new therapeutics and technologies and medications really has this perception that, we can, if we just study it enough and push enough or apply a certain technology, we will solve this problem. So it's become so compartmentalized and at a molecular level, we're not able to pull back to look at what really medicine was, as you said before, healing. And so much of that was the inability to fix anything and allowing the natural process of a disease to take its course. But the critical component of that was that the physician would hold the hand of the family members and the patients as they were passing. And it was really that shift. And so right now we have all of these, wonderfully trained people who want to fix that specific problem, but they just don't have those interpersonal skills or the really historical context to appreciate what's happened to healing medicine and society. So,
Dr. Patel, you just made me remember an old book called House of God with Samuel Shem. The first rule was the first pulse and emergency you take is your own, and you're mentioning that. Dr. Shana, if I could put you on the spot, you are in your second year of residency. You've come out of medical school. Can you tell us about how much of your learning in this has been experiential and how much has been formalized training?
So with regards to, having these tough conversations, advanced care planning, goals of care, during medical school, I almost had, I want to say, almost no exposure to this. These conversations were always behind doors, the fellows or the attendings would have with their family or the patient, and we were very removed during medical school. However, during residency, as an intern, we had spent a lot of time with our patients. Not so much on the medicine side, but when I started my ICU rotation, it kind of just, it hits you in the face because you're having all these goals of care conversations, really hard conversations, and you don't really have a foundation for them. But our attendings, fellows that I have in my training, they're very good. We usually block out an hour at the end of every day to call patients, update them. And it's almost an art, it's a skill that you build. And the more you do it, the better you get at it, is what I want to say. And just being open, try to build rapport, trust. But I'm still learning. They do a lot of little initiatives at our hospital. We have a whole block with like to vital talk. We have a great palliative care team, geriatrics, rotations. So all of this helps us do better.
I complimented an attending one time after a family meeting, something I always didn't need to do. And I said, how did you get so good at this? And he said, I sat in and listened to my attendings do horrible jobs and think, well, I wouldn't want to do that. And then I would hear those that did great jobs and think I want to accomplish, and meshed it into his capability. What about in the nursing perspective? I think you mentioned a little bit, Melanie. Melisa, your thoughts on this? How can we do better than we're doing now? I think we all kind of agree that we're making inroads, but we need to do better. What do you think we need to do as far as medical education?
I think definitely making it a more integrated part in the education piece of it, like in school. Doing mock conversations, allowing yourself to be exposed to those types of conversations as well, and calling on the experts, bringing in palliative care and hospice experts and picking their brains and letting them, speak and educate as well, because they're the experts on this. I don't know. Do you agree, Melanie?
I think, yes, I think leveraging, if you have those resources, I think more nursing school to be exposed and to have some training, like I mentioned. I remember when I got done with my dad, I wanted to send the entire care team Atul Gawande's book. You're fabulous caregivers and please read this. So I think that is, I saw that mentioned in the chat at one point. But I think it's just more exposure and how to have these conversations and lean into it. And and we really talk in palliative care, it is training, like starting an IV or ventilation, and yet we don't get that, or most of us don't get that training, at least in general medicine or nursing education.
So I'll use your IV example. Occasionally we miss when we try to start. I think that what I've observed in all kinds of healthcare professionals is when a conversation doesn't go well, they have decided that they're the worst ever at this, and then they start to avoid these conversations when we all strike out. I bet Atul Gawande has had some conversations with patients. Well, we know from his video that he had some that didn't go well. That we don't give ourselves enough grace as healthcare providers.
Agreed.
So
I would agree with that.
I feel like I'm preaching today, but that's okay. I don't get to preach in the wild. So my apologies to the whole community. Let's talk a little bit about cultural sensitivity. We have patients who come who are from various cultures, sometimes whose grasp of English is a little tenuous, sometimes who don't speak English. By the way, I can't think of anything more terrifying than to be in a country where my loved one is dying and I'm having to go through an interpreter on an iPad. How, what do you do to try to ensure that we are culturally creating that respect and that relationship? I think, as Melisa mentioned earlier, in a way that someone really understands. Dr. Patel, I know I may not understand everything you're saying, but I know you're trying to take care of my dad. And how do we do that?
I think it really needs to begin with understanding where the family is coming from. What is their cultural foundation? And these are things that you have to just take responsibility for yourself and learn. No one is going to give you a handbook on this. And so you ask them, where are you, where's your family from? Okay, how many people in your community are there? Is there a certain faith that holds you together? Is there a faith leader in your community that you go to for counsel? And it's shocking when you just kind of approach it this way. You'll get we are well supported and organized to the I'm here as a migrant. My family is in another country, and I'm pretty much not going to see them at this point. So really getting to know where they're coming from, and so you can actually begin these complicated decisions, I think is just a foundational thing. And there's really no way to get around it, but just you have those uncomfortable conversations. And I think that the misconception a lot of doctors have is, I'm going to treat all my patients the same because that is my oath. Well, that is true. However, in treating them the same, the goal is to give them the best of what you have to offer as a physician, as a caregiver. And a part of that is also to understand who they are.
Anyone else? Let's kind of add another rung on this. When we talk about ethics, bioethics in the US especially, we typically go with that Beecham and Childers fourfold ethics. But I'm always amazed that the word autonomy is the giant word. Everything else kind of hangs below that. So in the cultural context, when someone is expressing what they view as autonomy and asking for something that you know will not help them and indeed might hurt them, how do you navigate that space?
I think a piece of that is having an organization that supports you when you say this is not a useful intervention. I think a lot of times providers don't feel supported by their organization and feel like they have to either offer or complete an intervention that is going to be counterproductive to a patient or not necessarily harmful. In the moment, it could be a Band-Aid in the moment, but in the long term, it could be harmful. So that's tough. That's a tough one. I don't know. Also, just again, developing trust and rapport. That's some of the biggest things tools you can use when caring for people from different cultures and backgrounds. If they trust you, they're going to trust your word. They're going to trust that you're doing the best by their person. So it's a very fine line. It's a very tough place to be for anyone.
Are we too hesitant? Because I frequently will hear someone say, now, this will not help your wife. Are we too hesitant to say, in fact, I'm afraid it may harm your wife and cause her distress? Would that be helpful or not?
I think it goes back to some of the things through my family lens of establishing what's important to the patient and what their values are. What are they hoping for? What do they fear? I do think when I look back on my journey, they were giving my mom a menu of things to pick from, and I could read in between the lines that none of this was going to improve my dad's quality of life or even buy him hardly any time. But the care team we had was very reluctant. They just kept giving us the menu and wanting my mom to pick. And that's when I had to get very direct. I need shared decision making, because I didn't want my mom to feel like she made a decision that really wasn't a decision that either shortened my dad's life or and none of this was going to change the outcome or even buy a lot of time. But I needed the care team to, based on what we know about your husband, we would recommend not going through with this last stent and focusing on comfort. I needed them to say that so it didn't feel like a decision my mom had to bear.
Thank you for that. I know in some of the ethics consultations I was involved with, we failed to realize that we were giving options and actually asking someone to choose how their loved one was going to die. But that's how it was being received. So how do we, without being paternalistic in a negative way, get to the point that Melanie was just talking about, where we help a family by removing the 20 options? Intellectually, it's always great to step in and give someone a bunch of options, but Melanie, you're describing this not being helpful. How do you or the rest of you negotiate with patients and their families to pare this down and to help them get to that space?
An approach that I use is that I take the menu that everyone is given, and I use that as an opportunity to kind of be as equitable as possible to families who are coming from various cultures and healthcare literacy backgrounds, as well as to go back to the sort of mantra of above all else, do no harm, which you stated earlier. And so I would say, listen, dad has emphysema, and I show them the picture of what that looks like on the CAT scan. These are the holes in the lung. I think once they are able to have a visual, and then I say, this is an incurable condition. And then I'll go through the things that they can have. There's oxygen inhalers, addressing comorbidities. There's lung reduction surgery, and then there's lung transplant. And then I'll say, these are the reasons that these are harmful, and he is not eligible for these. And so kind of going through this menu and kind of reversing back to why these are going to be harmful and crossing those items off, and all of a sudden you're really not left with these robust sort of life prolonging measures, but you're left with essentially a path of palliation.
I appreciate a point that you made there, because not all of us are auditory learners, and some of us are more visual, and some of us more kinetic, and your method basically lets folks meld any of those to get to a certain point. Anyone else on this? I'd like to circle back to the cultural sensitivity, and that's obviously a big focus of medical education these days. We haven't broached the spiritual component of this, and I know there are chaplains online here, and you know, they'll have to give me a little leeway here to say often our spirituality is really ensconced in our culture. It's part of our cultural identity. Navigating with your patients, your family members, the spiritual components of this, you know, how do you do this in a way that's respectful? Especially in those cases where it's a theological or spiritual view far foreign from our own, and maybe you know, antithetical to ours. In other words, we know that if we pray hard enough, Keith will walk again. How do you negotiate? It's a very difficult space. What do you do? And it keeps me in a job, by the way. So please don't solve the issue. But how do you negotiate?
I think it is an extremely tenuous place to be. You can really alienate people by not addressing their spiritual side of things, especially if it's a culture of miracles, which I'm not negating miracles, but I've not seen a lot of them in my practice. So, for instance, we had a patient in our inpatient unit who was dying very miserably of pancreatic cancer, and his wife didn't want him medicated because she didn't want to block the miracle that she was praying for. And it created an incredible amount of tension between staff and the patient's wife. And it was just hard to watch this gentleman suffer like he did. The only thing we could do at the time was continue to support and educate the wife and the staff as well. So also being a resource to the staff that's caring for the patient. Understanding that you may never be able to shift that perspective is important as well, and trying to balance what's best for the patient and still be respectful of the wishes and culture and spiritual identity of the family. I don't have a good, quick answer for that because there isn't one.
Yeah, good.
Yeah, but knowing that every situation is different, every person is different, every caregiver is different, every person's different, and just being respectful of the space they're in.
We're having some good comments in the chat as well. I think you know, one of the issues of when you go for a consult and the medical team is angry because they say, well, they're waiting on a miracle, not realizing that miracle, the visualization of a miracle is contextual and elastic, and tends to to change with time. And that is part of the grieving process and the acceptance process, as some folks are saying. You know, we're actually getting closer to the end of our time together. So I want to make sure and give each of you a chance to respond to this. Moving forward, what changes or resources would you like to see to help patients, caregivers, and providers have deeper, richer conversations? And we'll just go through all four of you if we can.
Well, I feel like I'm always talking, so I apologize.
That's why we're here.
Ideally, those conversations to start earlier, to make it more a part of our culture as healthcare providers, primary care, physicians, home health nurses, all the way up the line, to start having these conversations early. Even when someone's well, you know, it's a part of life. We cannot escape it. We cannot escape our death. We cannot escape the death of the people that we love. This is part of our human condition. So normalizing that, making sure that resources are available in a very, in the appropriate language, appropriate cultural context, so that they're easily understood and available. You know, if we lived in an ideal world. But really, I think definitely starting those conversations early.
Normalization, thank you. Dr. Shana?
Yeah, I think when patients are healthy, we see them outpatient, that's a great place to start. We see so many establishment of care visits for patients, and you know, in our notes, there's blocked out sections for their medical history, their family history, what medications they take, what they're allergic to. It'd be nice to have a section for what are your goals? You know, if something were to happen to you, what would you want us to do? Just a little block that we also put that in while the patient is well. So at least we have a baseline. Is important. And then as they develop illnesses, you know, high blood pressure or chronic kidney disease, then adjusting their goals of care to that. It's a 5-minute conversation, and you do that when you see a patient every year, it can go a long way. When you're reviewing your notes or something in a critical care setting, when you're going back and reviewing notes and trying to figure out what this patient would have wanted, it can help.
Thank you. Dr. Patel?
I think resources ultimately bring up the question of systemic change, which is a beast. And how do we make a change on a large scale level in this massive country with such a different way of doing things every way we look? But when we talk about what can a health system do, and that doesn't require millions of dollars, I think some of the things I think about would be the code blue debriefing, for example. So a code blue is an event where a patient is unresponsive and essentially going to pass. Oftentimes their heart has stopped, and we would resuscitate them. So it can be 10, 15 people participating in something that can go on for an hour. Oftentimes the most common outcome is the patient doesn't survive, and it's extremely graphic, but there's no closure, there's no space to really acknowledge what has happened. Both the fact that if conversations occurred earlier, we wouldn't be here providing a futile thing that is traumatic for everyone and the family, but also as caregivers, as a team, acknowledging that this was a great moment of suffering and that we should care for ourselves if we're going to continue doing compassionate work moving forward. So I think there are things that can be done systemically that are in the purview of legislation and finance and whatnot. But I think there are some quite simple things that we can do in our health systems that don't require millions of dollars.
Thank you. Melanie?
Just trying to build off what I've heard, because it's a big, complicated issue, but trying to look at some things that can be done. I think the thing that is for all of us as clinicians to remember is it is not a one and done conversation. Do you want this? Do you want that? I think patients have a really hard time. Do you want CPR? Do you want dialysis? They just can't wrap their head around that. And it's not a one and done magical conversation. And I do agree the earlier it starts, because once someone's in a crisis and it's never been talked about, that is not, I've heard, let's have palliative care at Code Blue. That no, you're past. That is not the place for a conversation. So I do think earlier. The other thing I would say is, as we've worked as systems to better capture patient wishes, Epic is a beast in all of itself, and a lot of the work that I have done is to try to help make it more easy for patient wishes to be seen in the medical record once documented. And I think everybody has a place in those conversations. If we could break the hot potato conversation, well, it's not my job, it's not my job. Well, really, we all hold a piece. And as a nurse, thinking about my days at the bedside at 10 o'clock at night, boy, did I hear some patient stories. I didn't realize it at the time, but would have been very valuable to either share with the care team either larger or would be able to be captured into the medical record. So that would be the other thing. I think sometimes there's a perception that this is only the physician or the provider's place. And yes, they are the one directing the care and giving prognostic information, but that nurses, chaplains, so care managers hold a very important piece of the patient's journey as well.
You're speaking to the intense value of the narrative note in the advanced care planning section, which often is a blank spot, even in our most sickest of patients. And I beg in the education that I do, these narrative things are gold. When I can say, when so-and-so was talking to your father a couple weeks ago, he said blank. That means a lot. But I unfortunately see lots of empty space there. So what I heard from all of you in this question is was beautiful in that it wasn't, we just need to make the public change their perception. I heard it, we've got to work inside as well. And so I want to tell you all, I appreciate that as someone who frequently hears about, we just need to get the public to start talking about death. If we can't do it amongst our own family members, there's an issue there, isn't there? We've got just a couple of minutes. I want to circle back to you one more time, and then we'll do our closing. There are a lot of great comments in the side in the chat. I apologize we didn't get to it all. Lots of comments about Atul Gawande's book. That's great. Actually, if you get it, if you haven't seen it, please watch the Frontline video. It's a little old with Atul Gawande. I've been in conversations with 30, 40 practicing medical people looking at this, and it's intense. So please look at that. The last question for any of you, if you'd like to kick in, tips and tools that you think enhance conversations that help the cause. Anything that you haven't been able to say that you'd like to say now? Just creating this space.
I'll go first. A quick thing that I have been doing for a while is just to really acknowledge, like, I'm so sorry this is happening. Like, in very plain language, not a doctor language, just be like, I could see this being my mom. This really sucks. And I can't imagine what it's like for you being exhausted dealing with this stuff. And if there were a treatment that I could give her, I would do it. And when they hear that as just a person to person, it's like, oh, you're on my side. You're not, on the white coat side, so.
Oh, I appreciate that very much. Others?
Ooh, so I'll put my family member hat back on. I think it's just, how do we get clear communication to families, especially when serious illness, you have so many providers and specialists involved. I think that is what was very hard to navigate, is all the different pieces of medicine and how does that come together? Who's captaining the ship? And I wish I had an easier answer for that one.
Others? Just in case you are thinking before your answer, we did have a question about folks receiving pacemakers, and how early do you start talking about end of life decisions? And I'll throw in VADs, by the way, because again, I started seeing patients again, and then actually got too busy to see patients, but I was running into VAD patients who said, "Oh, I've made a huge mistake. I can't live with the psychological burden of this." Do you, in reference to Charlotte's question, any experience specifically with folks, especially with those ICDs, who tell me it was like I was kicked by a mule, I'm now scared to death? Any hints as to how you might address that? And then we're going to need to put a pin in it, but I'd like to hear.
Wow, Keith. Well, that's a whole conversation out of itself. But I would say anytime you're using these implantable devices, a start of a conversation about what it might look like down the road is important. And it's definitely not addressing us, even especially in the LVAD population.
Yeah.
Our LVAD team was especially good at really laying out what the future is going to look like. It's going to be hard. You're going to want to quit. You're going to have to rehab. So definitely making sure they understand the repercussions of their decision and what it's going to look like to be successful is extremely important, especially in the LVAD population, because it's hard. It's a hard road.
Yeah. Dr. Shana, any last words from you? I'm putting you on the spot, but I'm the other side of the state, so you can't get to me very easily. So anything you'd like to add?
I think as someone that's, just training and just growing, being open-minded, listening is so important, and not shying away from tough conversations. It's a skill. If you're uncomfortable, there are usually people that will help you. And being part of family meetings and not leaving everything to your attendings or the palliative team. I think just exposure is important.
So we're at time. I want to thank our panelists. This has been marvelous. I actually don't know any of you would love to get to know you all better. But thank you for sharing your stories and your perspectives. Also, I want to thank the North Carolina Serious Illness Coalition for inviting me to be a moderator this morning and get the chance to do this. Thank you all, those of you who are in healthcare, those of you who care for others. I'm aware, especially my brothers and sisters in healthcare, we all rush into places that a lot of folks want to run away from. And so thank you for doing that each and every day. And so again, on behalf of the coalition, my thanks. And as someone said, happy Thanksgiving, everyone. Thank you.